Good afternoon, everyone. The title looks a bit complex, but it's actually a simple, straightforward case. So this lady is a 48-year-old lady, homemaker, hailing from Surat. So she has been diagnosed as unstable angina, which is new in onset for the last 2 months, class 3. So she was seen by a local cardiologist in Surat. She is a hypertensive and her mother had a family history of CAD. So with this background, they did ECG, echo, which were normal LV function. So after putting on her some medications, then they did a coronary angiogram. This was also done in Surat. So ECG is normal, no significant STT changes. So this was the angiogram. So left side, they took only 2 shots because it was a normal system, cranial and caudal, and this is the right coronary artery, which is showing an osteoproximal tight stenosis and an anomalous LCX, which is pretty large in size, which is also having an ostial lesion. So what do we do next with a young lady with minimal risk factors and who has got an anomalous LCX and a bifurcation lesion at the proximal RCA? So we had 2 options in her case. So angiogram is not so clear whether the LCX has a separate origin or it is actually arising from the ostial RCA. So that we have to define. So if it is a separate origin, then we had a very good chance of going ahead with a V stenting or something. So if LCX is coming from RCA, then it is a true bifurcation lesion because both the branches are diseased and LCX is of reasonable 2.5 mm size. So how do we evaluate? So we had again go ahead with either intravascular imaging or we can plan a CT coronary angiogram prior. So in this case, we specifically wanted to do a CT coronary angiogram because of the following reasons. We wanted to define the LMCA ostium also again because she is a relatively young lady. So Takayasu's or any middle aortic syndrome where even the aortic branches are normal, but only the middle, the descending aorta and the abdominal aorta and the coronaries are involved. We see cases which are not so infrequent. So we chose a CT angiogram where the LMCA is completely normal and the aorta and its branches are also clean. And we got this information from CT angiogram. There is a short common trunk which is around 2 to 3 millimeters with a tight proximal RCA lesion which is about 7 to 8 millimeters in length, and the anomalous LCX also has an ostial lesion which is less than 5 millimeters, around 3 to 4 millimeters. So this is the information we got and approximate sizing of the vessels. So this is the CT angiogram. There is size discrepancy because CT also helps us in assessing the size of the vessel. So LCX is a 2.5 mm and RCA is a 3.5 mm. So we thought, what would we do? Because it's a true bifurcation, but only feature is that LCX ostial lesion is not extending beyond 5 millimeters. So we thought we'll go with provisional stenting as there is no enough length for pot. And rescue strategy in case we thought because the angle of the LCX is almost 90 degrees, we'll do a T or tap rather than a culotte. So we went ahead, we took a Amplat's guide, then wired both the vessels. So did pre-dilatation to the RCA. Then what we noticed was the flow to the LCX has actually improved once we pre-dilated the right coronary artery. So probably the reason is the stenosis of the RCA is starting from before the origin of the LCX. That may be the reason why the LCX is looking better after pre-dilatation of the RCA. So went ahead, 3.5 into 15 mm DES in the osteoproximal RCA with minimal protrusion outside. Then optimized the RCA stent with a 3.5 balloon only. And this was the result. So good flow in both the vessels, but at this moment the patient had chest pain and ECG changes. Although hemodynamics were stable, but she had, we waited, we gave some nicorandil, nitroglycerin and all that, but still she was complaining of chest pain. So then we thought the side branch pinching must be important. We are unable to clearly see, but there is definitely haziness at the ostium of the LCX. So probably some block shift or something must have caused it. So then we had to define the LCX ostium again. So again, we had an option of intracoronary imaging versus FFR. Here we thought physiological assessment is better. So we did an FFR to the LCX. So baseline was 0.83 and post-adenosine it was 0.64. So went ahead, we thought we could get away with a kissing balloon inflation. So went ahead, took a 3.5 balloon in RCA and 2.5 balloon in LCX and did a kissing balloon inflation. So once after kissing balloon inflation was done, so her chest pain came down and ECG settled down. Then we did a post kissing balloon inflation FFR. So it was 0.92. So this was the final result. So seemingly an extremely tricky and complex case, but CT CAG has immensely helped us in planning the bifurcation, especially in anomalous coronaries. CT coronary can predict the malignant course also. So CT coronary is a good option in evaluating whenever we are dealing with the anomalous coronary origin. And physiological evaluation always helps in decision making about the side branch, and we can end up with a simple single stent in a complex anatomy like this. Thank you.